Clyde Shallenberger. I'll tell you a little bit about him in a second. My name is Mark Hughes, co-chair of the Ethics Committee and a faculty member of the Berman Institute of Bioethics, both of whom helped to sponsor this event. We're going to work on some MDiv. As you may see if you come to other Ethics for Lunch, we're in the auditorium this month, which means we can't bring food into the auditorium. So after the presentation, you'll be able to get the food and carry it with you to your next event after the presentation, so you can grab that on your way out. So let me tell you a little bit about Clyde Shallenberger. He was a director of pastoral care here for 30 years. He started in 1963 and retired in 1993, but continued to serve on the Ethics Committee after that in his retirement. He served thousands of patients here at the hospital and provided that spiritual care and support for his time that he was our main director of pastoral care. His sort of leading work led to things like we have now for the chaplaincy residency program and really an attention to spiritual care at the hospital. In addition to his work with patients and families, he was also instrumental in supporting the staff members here at the hospital. So in today's world we have things like the RISE team that provide that support in crisis situations. Clyde was the person that did that for those 30 years that he was here, really trying to provide the emotional and spiritual support that people needed as they dealt with tough situations. After his retirement, as I said, he continued to serve on the Ethics Committee and really was a forerunner of what he called the God Squad. So thinking about these issues going back into the 1970s and 1980s of tough ethical dilemmas and how a community of people could think about these issues and try to resolve them. He's unfortunately not able to be with us this year, but we really wanted to recognize his contribution and know that this is an annual event to really honor his service to Johns Hopkins Hospital. I'll now introduce Cinda Rushton, our other co-chair of the Ethics Committee, and she will introduce our speaker for today.
Thank you, Mark. Hello, everyone. It's really always an honor to honor Clyde. And today we have a really fabulous speaker for the Shallenberger Lecture, James Corbett. James is a seasoned healthcare executive and a bioethicist, which is an interesting combination. He brings over a decade of leadership in the C-suite, working for both for-profit and non-profit sectors in the industry. James served as a fellow at the Harvard Medical School, in the Harvard Safria Center for Ethics, and in the Nashville Healthcare Council. He also served a 4-year term at the National Institutes of Health, National Advisory Board for the National Center for Nursing Research, which I'm really proud of, and proud of his service in that arena. He has served in 4 health systems, providing both strategic and operational leadership for research, innovation, global health, behavioral health, and providing leadership in terms of hospital housing development, advocacy, and ethics. And I think what you'll find is that James brings a very unique combination of skills and perspectives to his work. He has lectured at many prestigious institutions, including Harvard and other universities. He is a principal in Initium Health, which is a boutique consultancy firm and public benefit corporation committed to using innovation to improve human health. So please join me in welcoming James Corbett.
Many years ago, when I worked in a hospital on the East Coast, a patient walked into our ER exhibiting erratic behavior. This patient was not admitted, although we had space in our unit. That patient walked out of our ER and walked in front of a train. I often think about this patient and my role in his demise. See, I was charged with improving our revenue in our psych unit, which meant taking commercial insured patients, and this patient was uninsured. I've come to think about that time in my life and the experience as a conflict of obligation. The obligation we have in our professional identity, our professional roles, and the obligations we have as humans, as a father, as a son of God. The challenge is that when we don't deal with our conflicts of obligation, they turn into moral distress. And moral distress can lead to burnout and unhappiness at home and lack of productivity at work. My name is Corbett. I'm here today to talk to you about reimagining community and moving beyond notions of charity and charity care. So before we dive in, I want to talk a little bit more about myself. We're going to talk about these 4 issues today: conflicts of obligation. We'll spend some time talking about imagined communities, play on a book by Benedict Anderson. We'll talk about what I'm calling the opioid generation. I do believe we'll be defined in the future as the opioid generation. People will ask what we did about it, and why don't we do more. And lastly, I'll close with a playbook. I don't think it's fair for me to come here and theorize without giving you some practical steps as next steps. So as a start, as Cinda mentioned, I have both a law degree and a Master of Divinity. Whenever I tell people that, they kind of give me the look they're giving me now. Usually I get a few chuckles. And the next question they inevitably ask is, what did you do first? So they can peer into my soul. So for the record, I went to law school first and then divinity school. And I'll leave it to you to decide if I've been ruined or reformed. So with that as a backdrop, I'll say that after serving in C-suites for 15 years, I decided to start a public benefit company about a year ago. And I'm serving as a bridge with hospitals and health plans and innovators across the country. Those guys that come in with hoodies and say they're going to transform healthcare and don't understand what Medicaid is. I work with them a lot, and I help them to rethink what it means. I was lucky enough to have an appointment at the NIH, the Nursing Research Council, not a nurse, but an ethicist. So I saw a lot of innovation coming in through the NIH, and I led our research operations in our last job with over 300 trials, medical devices, clinical trials. So let's begin. And Initium, by the way, is a hard spelling, but it means new beginning or origin in Latin. The reason I have that as a title is because I think it's important as we think about innovation to make sure that we don't throw out the past. Everybody wants to innovate and have all the great ideas, but it's important to make sure we have that institutional memory as we move forward. So we could talk about a lot of different things today. This is a kind of intimidating map of the ecosystem and all the things we could talk about, but we're not going to talk about today. Things we are going to focus on is kind of behavioral health, hospitals, FQHCs, and tech companies, all through the lens of ethics. And I think for me, when I think of ethics, there's a famous article called, "Can a corporation have a conscience?" And the question is, of course you can have a conscience, but it doesn't come from the top down, saying these are our values, swallow. It comes from everyone understanding and bringing their values to the organization, from the bottom up, and shaping the organization with full agency so they can live up to its greatest heights and fully embrace the mission, the great mission that you have. For me, it starts with the room where it happens. I don't know if any of you had the privilege of seeing Hamilton the play. There was a song sung by Aaron Burr. It said something to the effect, "I want to be in the room where it happens, the room where it happens, the room where it happens." He was arguing that he too should have the opportunity to be in the room and to share his ideas with people like Jefferson and Hamilton, deciding where the capital should be, and who got to thrive and decide where the treasury would be reside, but also be owned by. So I think what I like to say is that the modern room where it happens is a boardroom. And in these boardrooms, decisions are made at rapid speed pace, yet they affect millions of patients and employees. And we don't spend enough time processing those decisions. One of the things I instituted as an ethicist in one of the systems was after we made a big decision, we couldn't implement it for 24 hours. We had to do a values-based assessment as well. So it's called a values-based decision-making process, where, okay, we made that decision, but now let's more formally make sure that it ties to our mission and ties to our values. And You couldn't do it by email. The first question I got was, can we do this by email? No. We're going to gather again. We're going to have the same conversation, this time with a focus on the values and the mission of the organization. I'll tell you other things that happened to me, at least in the C-suite, is when I was a young executive, my first job, I raised my hand in opposition to a vote that everyone else voted for. And I guess I was very naive because VP of HR looked at me and said, wow, that was very, very brave of you. And I didn't realize it was brave to disagree if you thought another opinion. The group think was real. And then after later that day, I saw my CEO and she said, that was kind of interesting what you did. I didn't know I did much. She said, that was what I would call a CLM. I said, what's a CLM? Anybody know what a CLM is? I didn't either. It's a career limiting move, she explained. Thanks. Learned a lot. In other institutions, when meetings were happening that I was supposed to be a part of, I said, hey, how come I wasn't at that meeting? I said, oh, we thought you'd be busy. A signal to play the game, to be a part of the team, to not ruffle feathers enough, so they wanted to. So there are a myriad of challenges in the room where it happens, and the stakes are high, because I argue when we make these decisions in the room and we don't pull back the corporate veil enough, everything doesn't need to be completely transparent, but we don't need to hide as much as we do at times, at least in the C-suites I've been in. And you can lead to what's called moral distress by those on the front lines. We have these great ideas in the boardroom. We don't invite others in to help us process those ideas. We say, now run forth and go forth and be merry. And what do folks do? They do the workaround. They say, that's a great idea, but it's going to impact patient care, so I'm going to go this way. And this book highlights the challenges for both the institution, but also for patient care of these workarounds. So I argue it's both a moral and a practical implication and imperative for us to think differently about how we make decisions from the top to the middle of institutions. How do we solve it? The hairball. So this is, for me, a metaphor to show that I believe healthcare is a hairball. I believe it's political. I believe there's administrative burdens. There's a muck at times. You can get caught in the muck if you don't allow yourself to think about it differently. There's tremendous resources in every institution, tremendous academic minds. And it's important to stay connected if you're an innovator from the outside. Don't spin off into the stratosphere with these great ideas, but also don't get caught up in the muck. It also remains relevant for those inside the institution to make sure that they don't get caught up in the day-to-day in a way that allows them to lose themselves, allows them to not remember why they started in the institution, and stay relevant with big ideas and the question expanding notions of happiness and assumptions. I'm going to pivot now to the imagined communities. As I mentioned, Benedict Anderson wrote a book called Imagined Communities, and that book really talked about nation states and how nation states are built. The classic example is Africa, where Africa is carved up without regard to geography or ethnicity and culture, done by the colonialists, obviously. But then it became real. These imagined communities became real communities with barriers, restrictions. I think what I would argue is that that's a metaphor for what happens, unfortunately, with hospitals and the communities they serve. Johns Hopkins is in Baltimore. So when we start talking about what happens outside the walls as if the community is somehow different than where we exist, it doesn't really make sense. In fact, if we think about it this way, maybe we should use words such as discharge. Where are we discharging people to? Into the community? We're a part of that community. By the way, is discharge a good word to use for someone who want to be called discharge or dischargeable? In the same vein, does it make us think about patient quality committees differently? I've been a part of institutions that thought about, instead of calling it a patient quality committee, maybe we call it the community health value committee. And we live up to our mission more formally. And we lay measures on there, social measures such as air quality, crime, housing. Even if we're not going to fix it, maybe it's important to have it listed there so we can think more formally about our role. So hopefully when we think of the imagined community differently and our role and responsibility differently, it allows us to think more creatively about what's possible. At the same time, we know that there's things that historically have happened inside the hospital and outside the hospital. Healthy behavior and other issues have been formally considered things that are addressed or at least applied to what's called the social determinants of health. Housing, education, nutrition, those things lead to better health and at times have been outside the hospital purview. But I would argue today there's a tremendous understanding that the social determinants of health can help to decrease the length of stay. It's a financial opportunity because folks who are staying here too long are at risk for reducing the revenue of the organization. But at the same time, it's better for the patients. I call it doing good, doing well. There's nothing wrong with that. To understand that if we can get folks back out of the hospital quicker, less likely to catch hospital-acquired infection. So this question of thinking about social determinants of health can affect us on our floors. It can also affect us, obviously, in the emergency room. You're in a very hyper-competitive market here. If you have folks who are in the ER for social issues that we have failed to address in their communities, we can experience what's called left without being seen. Just we need another acronym, right? LWBs, left without being seen. When you study those numbers, it's a significant number of people who have registered, have decided they don't want to wait long enough, and walk out of the doors. It's an over 7-figure number, I can tell you that. So there's opportunities to rethink that and to spend those resources in the community so that folks aren't unnecessarily coming into the ER. And what you'll hear from me consistently through my training is a question of how do you handle it theoretically and practically. One of the examples of some work I've done in some institutions where I had a for-profit health system hire community health workers. Not an easy task. One of my former colleagues is in the audience here today. So I went to the CFO and I said, I have a great idea. I want you to hire community health workers. He said, social workers? I said, no, community health workers. And I explained the model. And my thought was, and I wrote an article about this, I gave our community health workers iPads. And I said, people who come to the ER and start the application process but don't complete it, cost the hospital a lot of money. So what we can do is with those iPads, you go to their homes, you go to the jobs, you complete those applications. And then because you completed those applications, you got paid, the hospital got paid retroactively. Within 60 days of that initial visit, they could still get paid. Those community health workers were generating $5 million a year for the institution. So when the inevitable cuts came, those weren't the ones on the line. So for those of you who are on the front lines who feel like at times it's all about the money, it doesn't have to be about the money. I can tell you, you're smart enough to focus on the financial issues and get your efforts done. To me, the finance is not hard, it's just not that interesting. So maybe together we can work on issues like that to move the dial. We all know that the system has allowed it to be carved and separated, and that we need to have the physical and the mental together, and that we need the social care and the public health together. But how do you do it in a meaningful way? I would argue that the FQHCs are an underutilized resource. I know I had the privilege of meeting with Lisa Cooper yesterday at dinner, and she does a lot with the FQHCs under a big Corey grant. And I have to say, the $13 million grant that she achieved is something that is pretty outstanding for the organization. It could be a precedent of what's possible. When I've worked in other markets, we looked at the ER usage, and we geo-mapped the ER usage and how far folks were coming to that hospital. And I will tell you, in states like California, they're driving 75 miles to get to a hospital for non-emergent care. It doesn't make a lot of sense. And by partnering with FQHCs and these different locations, we're able to leverage their network of community partners so that we can address the social determinants of health with them and keep patients in the right care, the right setting. I'm not being Pollyannic. I know the challenge of federally qualified health centers. At times, they're going to want some technological support. They might want some specialist support, but there are affiliation models at work. And it is an opportunity to provide better care for our patients and the communities they live in. At the same time, the great thing about the social determinants of health technology that's happening across the country, there are a myriad of companies in this space, from the Aunt Berthas of the world to Unite Us, Democratic, Title, to NowPal. And all these companies allow you to do social screens in addition to medical screens. And by marrying the two together, you can figure out, one, the physician can ask a question that they previously didn't want to ask because they didn't have an answer for. And two, these closed-loop referrals allow you to say, you went to a food bank, you went to Catholic Charities, which one had more impact? So the care that we provide is being transformed in front of us, and tremendous opportunities are in the space. One of the biggest is called NowPal, and it was created by Kohler Eris, Kohler Faucets, based in Chicago. She decided she wanted to create a social determinants of health technology company. And right now she has this technology company, and she's hiring community health workers who leverage that technology in order to understand the patients more deeply. And in the era of value-based care and the emergence of Medicaid, social determinants of health technology is something to consider and monitor as it improves the care of patients across the spectrum. At the same time, the time has come for us to think about Medicaid differently. We can no longer think of Medicaid as one cabal of individuals that just don't hurt us financially and really we can't address it. In states such as California, 37% of the population, 37, is now on Medicaid. So you can't think of it as something that's not part of your care. In fact, I would argue that we have to think about Medicaid based on the federal poverty limit, and that we have opportunities to go a little deeper in terms of carving that population and providing care for them. Those under 50% of the federal poverty limit, generally homeless, maybe undocumented, one level of intervention that needs support of social determinants of health. Those on the top level, above the 100%, those that were allowed to come in Medicaid from Obamacare, that's a business opportunity. Those folks aren't going to be on Medicaid forever. A lot of them will be moving into commercial care. So providing care for them means in a hyper-competitive market, maybe they'll be your commercial payers of the future. I'll also say that in California, a very interesting thing happened about 6 months ago. The residents came to the State House, and they were knocking on the State House door saying, we can't get care on our specialty care because we're on Medicaid. And how ironic is that? The future doctors of the world are not able to get specialty care because they too are on Medicaid. So we have a problem. We have an opportunity to fix that problem. And when you think of problems, pivot to the third, what I call the opioid generation. One of the biggest challenges of our time, where over 115 people are dying a day due to the opioid crisis. Right here in Baltimore, your ER has 9 times the national average associated with this issue. And increasingly, the African American community is facing this as it relates to heroin, and heroin impacted with fentanyl, which is leading to a tremendous overdose issue. And I'll say that, they're not going to look and say, oh, the farmer in the future, because history has our eyes on us. They're not going to look at the future and say, oh, that was a farmer company, or that was the doctors only. We are all part of this. We're all watching it happen. We can all play a role to the solution. I can tell you, I've sat in my office, had a mom come to my office with a book, and the book was When Your Heart Belongs to an Addict. And it was a torturous story, hard to read, of her 9-year journey, which ultimately ended with her son dead, recycled in and out of the hospital. Another mom wrote us a letter. She wrote every administrator a letter. She said, my son came to your hospital and is well known to your staff. He's been cycling in and out of the hospital for years. On this particular day, you chose to discharge him. You discharged him with no one to care for him. And she said his blood level was X, his issues were Y. And she said, I want you to know that they found him a week later in a ditch, in a car. She said, I'm not here to sue you. I just want you to know that he had a mom, and that if someone else comes into your organization exhibiting those behaviors, I want you to recognize that he has a mom, and his mom would do anything to spend just another day with him. So I think the opportunity for us to galvanize and have a modern day mothers against drunk driving is there for us. And I do believe there'll be the moms that will help us solve this issue, and solve it with us. At the same time, there are some pockets of hope on this issue. And we'll say here's a tale of 2 Portlands. One is Portland, Oregon. One is Portland, Maine. In Portland, Maine, one I had the privilege of being a part of this, where we were able to have a mother's location where mothers and their children could heal the community with those in a lived experience. Where they lived there, and we supported them with housing and education and job training. In Portland, Oregon, the same models there. On the ground floor, you'll see a commercial space where people have the opportunity for job training and education, in addition to outpatient services and housing. In fact, to go a step further, I'm lucky enough to be working on a project in Dayton, Ohio. So Dayton, Ohio is in Montgomery County. That's where ground zero is for the issue. Apparently, all 3 major highways hit in this one little community in Dayton. And Google, through their arm, Beryl Lee, is now building a state-of-the-art recovery campus right there in Dayton, Ohio, where you have the inpatient, outpatient, you have recovery housing, and then you have a family unification center where they bring families back together who've been alienated and separated. Part of what that's happening to, what's causing that, driving that, is the fact that Ohio spends $40 million a year on the care of people who've been separated from their families, much of it driven by the opioid crisis. So how do you spend those dollars more wisely in a preventive manner? So when I think of things that are important for us to do on a practical level to impact some of these issues, I mentioned the importance of geomapping. In geomapping, the patients are coming to our ER and our hospital based on different factors, socioeconomic status, and others. It's important to segment a lot further than we have in the past and to think more profoundly of what's possible. It's important to partner with non-traditional partners. It's never easy to partner with those who can speak different languages at times. I've started medical legal partnerships in many institutions, and even the cultural differences between lawyers and physicians is hard to overcome. But the importance of that can't be overstated. One of the classic cases when you have these medical legal partnerships is what you do, you carve out your social work into more of a kind of isolated focus. So the most complex cases are dealt with over here, and the everyday cases are dealt with in a different manner. You put lawyers and others together and they work on these issues. classic case is a patient who's cycling in and out of the ER for lead-based pain, and the landlord refuses to fix it. And oftentimes you give that patient a lawyer, the hospital paid for, and it's generally just a call. Inevitably it goes something to the effect, hey, I'm here representing patient X, and the landlord says, oh no, I didn't know that was an issue. No, you didn't know this poor person had a lawyer, now fix it. Problem solved. Patient not cycling out of the ER anymore due to lead-based pain. So there was ways to resolve it creatively. Financially, if you do the math, it's more effective at times. The interoperable social determinants of health technology I mentioned is very relevant. At times you can get the payers to fund it, or Medicaid, managed Medicaid companies, and other payers to fund that technology that can support and marry into the EPIC, which I understand you use in this organization. Behavioral Health Summit. I would argue that bringing folks together in a different way and hitting a reset button, particularly with the increase in spikes of overdose deaths in this community, is very important. And I know at times working with the behavioral health organizations and other advocacy groups can be a challenge, but I don't think that Hopkins is going to solve this issue alone, and I don't think they actually need to own it, but they can lead in a different way. They can be the boundary spanner. They can bring folks together and think about the importance of technology on an emerging crisis in our country. When I say lead without authority, I think it's important to kind of unpack that a little bit. I've been a part of collaboratives where you bring the police department, the fire department, others together. In Portland, Maine, we called it the home group. We brought them all together around the table. We got the business association to pay for it. They were tired of seeing people laid out in front of their businesses. So Portland, Maine is a small community, but it's a very lobster community, lobster-oriented community. So a lot of lobstermen would come, make a lot of money with their lobster, and come back and drink themselves sick and be laid out in front of the offices. In fact, the police chief, who's now the police chief in Detroit, he came to Portland, he said, what's all this layout stuff? I don't understand layouts. And then inevitably it was the same patients laid out in front of businesses. They created a home team to support them. And it took the burden and the cost burden off the police department. For some reason, whenever you had an ambulance come, they had to have the fire department come as well, some outdated regulation. So we were able to reduce costs, have it paid for by the business community, and do a little bit of a better job of substance use in our community. And this conflict of obligation, I mentioned it earlier, but I think the importance of having the opportunity in the space to process big decisions is something that the institution can help create. And there's tactical ways it can be done to do that. And lastly, story. So what's your story? What's the story of Johns Hopkins? When I looked at the mission statement of Johns Hopkins, it was very clear that there was a vision around the community and impacting that community's health. That the measures in that community outside the walls aren't where they need to be. I would argue to live up to our greatest hopes of the mission mean to address it more forcefully and more formally. I just came back from Israel. I was in Israel for a week. I went to the Wailing Wall, went to Jerusalem. The reason I went there is to study innovation. In the US, everyone talks about we're doing innovation, but innovation becomes an empty word when everyone says they're doing it. So in Israel, they're called Startup Nation. And there's this innovation center. Waze, for instance, was founded there, along with a lot of other large companies that weren't aware of. In this innovation center, we had a speech by Shemi Perez, the former Prime Minister's son. And the book was entitled No Room for Small Dreams. And it highlights the importance of focusing on big ideas. What's interesting about that country is when you fail as a startup there, they see that as a beneficial thing. The next investor said, oh, you failed the first time, so you're going to get it right this time. They'll give you more money. They don't put a big L on you and say, no, we're never going to fund you the next time around. It's the opposite. So I've asked, and I've talked about a lot of different topics, but I think the importance of giving a second and third and fourth chance to get it right, and to give big dreams an opportunity is something we should put a pinpoint in. Hopefully it reanimates you, it re-inspires you to do your job with a little bit more focus on what is possible, as opposed to the muck of healthcare. It does require taking down your corporate armor, though. We all come to work in these corporate roles and these corporate identities, and we become defined by them. When I was in one of my jobs, I'd walk down to one of the community hospitals and they'd say, the suit is here, the suit is here. Like, I was wearing a suit, so I learned to not wear a suit. And they started making jokes about me being an empty suit anyway. So I learned a valuable lesson. So when I think of the mission of John Hopkins, it's so noble. It's such an opportunity to think big and to live up to the responsibility and the obligation of being a Johns Hopkins employee. I also want to highlight a quote that I found that inspired me. Was what Johns Hopkins imagined when he saw this place. He imagined a university at a time, and a hospital at a time, when people of color or women didn't have opportunities. He imagined that hospital to create a new way of thinking with a focus on those who could not pay. We've transformed that subsequently due to Medicaid, Medicare expansion, and large insurance dollars. That's not where we started. And it'll look different today because we're in a different time, but I believe it's a living tradition. I believe we all step into that tradition and play a role. So I'm very hopeful that as you move forward, some of the words that may will help you to orbit the hairball, to address your conflicts of obligation, and to reimagine the community and your role in it. Shalom, and Godspeed. So it ended a little early, but we can open it up for Q&A. I know I talk fast, hopefully not too fast. It's a New Yorker in me. So any questions? I have one in the back, and I think he's coming up with a mic.
Thank you. Thanks so much. My name is Deborah Matthews. I'm a faculty member at the Berman Institute. You mentioned early on the addition of the values-based decision-making meeting. Did you ever reverse course following that meeting? So you made the initial decision, then you got together the next day, had the values-based discussion. Did that ever lead you to change course?
Absolutely. And oftentimes.
Can I ask the second question, and then I'll give up the mic. My second question was about, you were talking about the social determinants of health and hospitals stepping in to pick up, incorporate more of that into care. But there's been, especially in the last couple of years, a tremendous amount of breakdown of the social safety net. And a lot of those pieces are getting picked up by other community-based organizations like hospitals and schools, the police department, et cetera. I mean, how much can and should hospitals take on versus advocating for reinstitution of the safety net?
So 2 questions. I'll start with your second one. Your second one is kind of how much is the hospital's obligation to take on these issues when maybe they're better served in other locations. So I think the answer is yes to both. One, can we advocate for support in these safety net institutions and others? Yes. But 2, I'll go back to the mission. The mission statement said to improve the health of the community, and health is a broad term. And I also do think that the social determinants of health technology makes it easier than it ever has before. Imagine if you refer someone to a food bank and they're diabetic and you gave them a certain protocol and you know if they even went. So they come back next time and say, hey doc, I've been trying everything and it's not working. You say, well actually you didn't make that appointment. Imagine if somebody, you referred them to a meeting and they didn't have transportation and you were able to click a button and have them connected with that transportation. It meant they would show up a little bit more. So I understand, I've been in C-suites and I understand that managing the bottom line, but there's real studies that make it clear that if you look at the length of stay, if you look at untreated diabetes in the ER, we go on and on, addressing the social determinants of health is a smart investment. Now here's the challenge. We know that people cycle off and on insurance. So here I am working to get you healthy, and if you cycle off and you go to another institution, our competitors, I just invested money in you, and maybe I'm not going to see a return on that money. And that's a policy issue that I think we need to think about, but I think the opportunity is there. Your first question was the question of, does it work, the values-based decision-making process? Absolutely. And part of it is, like, we make such fast decisions. I mean, I don't know if you've been a part of this, but I've been a part of quick decision-making, and then we think about it a week later, like, oh, what did we do that for? And then we're going to pull back, right? One of my last employers was famous for that. We do things quicker than anybody, and then we'd all say, yeah, and then you do it again and again and again. So I think sitting back and processing things with the understanding of the values and unintended consequences has had tremendous opportunity to do so. The challenge is it's hard because we're all fast-paced execs and we're driven, but the decisions we make, be it the insurance for our employees, to the staffing ratio models, the service we're opening and closing, they have tremendous impact on the lives of our patients. So to ask for 24 hours is not that big of an ask, I think.
Very interesting presentation. I'm David Myers. I'm a retired ER doctor and a bioethics grad student. We hear the conundrum about there is no mission without margin. in the C-suite all the time. And I think in many cases, the C-suite feels by having an ethics and compliance officer that they have actually addressed the ethics of what they're doing in the way of business. I'm curious to know how one overcomes the momentum in the C-suite that believes in the mission and thinks they're accomplishing it, but if you go to the sharp end where the actual care is being given, there seems to be a big discrepancy in their view versus those in the C-suite. What are your suggestions for overcoming that large gap and getting to true ethical consideration in the budget process, for example? Budgets are really moral documents. Just to speak about that, if you would.
Yeah, no, it's great. So just a couple of things. So I had the privilege of working in a health system that went not-for-profit to for-profit. And this challenges that you're talking about were pretty stark there. So we had two quotes. One, it was they were small, struggling non-profit hospitals that all of a sudden overnight became for-profit, driven by private equity. So our first quote was, it feels like Google has met the Department of Motor Vehicles here, right? The crash of cultures. So it really understood the importance of culture, which is really, I think, the basis of your question. And then the second point we had, which is the most damning, was, and it was a common dialogue, was the only thing lower than productivity around, no, the only thing lower than morale around here is productivity. And we could show that. People were checked out. They weren't taking the extra step. They weren't taking the extra call. And the importance of that was impacted on our patient satisfaction scores. It was impacted on our employee satisfaction scores. So I think in that regard, I mean, you know, healthcare execs are a driven bunch. They're going to be driven by data. They're also driven by things, and I'm not speaking about this group in particular, but I'm speaking about the institutions I was in. The one thing that we always hit, we miss a lot of things, but the one thing we always hit, again, I'm not talking about this institution, was our bonuses, because the bonuses were significant. So if you want to change behavior of an institution, follow the money. And I will tell you that there's obligations and responsibilities, fiduciary responsibilities of the governance and boards to inspire that we focus on what matters most to the patient. Now again, I don't want to be naive about this because I say that it's both, to your point, mission and margin. But I will tell you that that term has been changed and transformed from the person who wrote the original book. And the guy who wrote the book on that's based in Boston. He's an ethicist. And he's disheartened by the way that's been used to make tough decisions. No mission, no margin, whack. No mission, no margin, make an informed decision. What that intended to mean was to think deeply about your mission and be creative and to dream big so that you can live up to your mission and not leave patients behind. It's a challenging question, but I think there's opportunities there. And it really ties all of us better understanding the financial model and being a part of a broader conversation. So let's pull back the corporate veil. Let's get moving where it happens. Other questions?
What are your thoughts about free programs, particularly for the non-documented that we have here in Baltimore? Is it workable to have free programs? Does it add to care?
What's your role in the organization, out of curiosity? What's your role in the organization?
I'm on the ethics committee and I'm an ophthalmologist.
No.
We have some free programs at Wilmer Eye Institute. That's why I asked.
Yeah, I was curious the location. I've done a lot of work kind of globally, some work in ophthalmology as well, to bring ophthalmologists to other countries. You know, it's a complicated question. I mean, there's so much need. There's need from the undocumented, there's needs from documented. One of the greatest needs, unmet needs in this country is in rural countries. I've worked in some rural communities where hospitals are closed and they drive 150 miles to get to care. So I'll say that I think, if you go back to this statement, I mean, this institution was founded with a lens towards those who could not pay, you know, a small number of those that could pay. So I think in some respects, if you always want to return back to your mission and see that as your North Star, you've got a very powerful statement there. Now the devil's in the details. There's ways to do it in the ways that you don't lose your shirt. And there's ways to have policy conversations where you can get an increased subsidy to care for the undocumented. But I always return to the mission statement as a way for the past and a way forward. Your mission statement and the aspirations of John Hopkins are pretty clear.
Thank you.
Other questions?
I just wanted to address the productivity question that you kind of touched on. One way to motivate people is you have your patient, you have all your consumers, be able to be interactive, just like Uber does. Hey, I didn't like that. And all your bosses know it immediately. How come we don't have that? It's very easily done.
Yeah, that's a great point. I'll return to my time in Israel. I just got back Saturday actually, so I'm still 9 hours ahead and feeling a little bit like it. But I'll tell you that, Sheba Memorial Hospital is the top 10 hospital there, top 10 in the world, okay? Top 10 hospital right there. And it's fascinating. I mean, they basically have a hospital, they're ready for the next bomb. They have a hospital that's ready to be built or created in 48 hours, 2 levels down in their parking garage. Insane, like beds and everything ready. They showed us how it happens within 48 hours, insane. And one of the things they do there is they allow anybody to come in and do innovation. So if you wanted to do innovation in a top 10 hospital right now, they would open the doors for you. They would teach you the things you need to learn. They would bring you right inside and put you in scrubs and show you the workflows and on and on. So I think that those types of opportunities are things that are hard for health systems in this country. But if we could do that type of innovation, the question that you're answering and the questions that many patients have asked, would be answered. It should make us all disheartened that hospitals are not seen as the headlights of innovation. We're seen as the taillights of innovation.
This would be at all levels, the patient, sure, but how about all the employees?
I'm sorry, the question.
All of the employees, all the levels of employees. You don't get any feedback in an active manner.
Yeah.
And we should have that. It's the 21st century.
I think it goes to the culture of the organization. That's probably beyond my pay grade. I might have stepped on a few things already, so let's step on. But I agree. I think that we start giving people names such as patients and employees, and we forget we're humans helping humans. And I think there's a strong connection between employee satisfaction and patient satisfaction. So if you want patients satisfied, we'll make the staff satisfied. And oh, by the way, one of the most challenging things I've heard since I've been here is, the amount of violence the staff is undergoing right now. And to me, that's really disheartening that patients and others feel like they can chase down the staff or injure the staff, someone who's here to help them. So I think we're all caught in this up. We've got to hit reset.
I have a question about religion and spirituality and where you think that role is, where you've seen that important and how it's been initiated in hospital circumstances.
So I worked in many faith-based institutions where I'm entitled SVP of mission, so that we live up to the mission of the organization. And Catholic hospitals have done a job where the nuns used to own hospitals and used to actually be on the front line administrators, and they pass it off to the laity. And so my job was there to make sure that the spiritual needs of patients were met, in addition to other needs of the organization. So to me, it's very important and it's personal. I'll tell you that, and we didn't talk too much about kind of some of the historical things here, but for me, the importance of meeting people where they are and understanding their spiritual needs is something that I don't think we do a good enough job on, and I think we can do better in that space. There's also studies. I went to Duke Divinity School, and they have a study that's pretty well respected now. It showed that a group of patients were prayed for and a group of patients were not prayed for. And the group of patients that were prayed for had better outcomes, even if they didn't know they were being prayed for. So I believe there's a value there. At the same time, I think we have to balance it. I am tremendously troubled by some of the things that I've seen happen in faith-based institutions, from those that get to be hired based on their faith, to those who get to grow in the organization based on their faith. And I think at times there's been a kind of sick twist here where the faith of an institution has been used as a shield for very unruly behavior. So I think, yes, I see the benefit of it, but I think it deserves more scrutiny as well.
This is a very secular institution. I don't know whether it's different from institutions where you have been, whether you think that promotion of religion and spirituality is helpful for an institution, whether you've seen secular institutions like ours that you believe may be suffering.
Yeah, so you got in a very, something I spent a lot of time thinking of, I'll say. So let's talk about for-profit and non-profit. So should for-profit there exist? HCA just experienced their 50th anniversary of Health Corporation of America. They have 200 hospitals. They have 5 hospitals in London, including Princess Grace and London Bridge Hospital. Because we're in the era of this mega health system, and people don't realize how many times that you're connected. So I think there's things to explore there. I'll say on the for-profit side, we can't give not-for-profit hospitals a free pass. study the data. Sometimes their tax exemption is here, and their impact in that tax is here, and we need to figure out how to connect those two a little bit more formally. Look at the surrounding communities of large, not-for-profit hospitals. And on the faith-based side, I will tell you that I've been a part of some faith-based institutions that have really been challenging, and I'm starting to believe that maybe faith-based institutions should not be a part of healthcare, and it's sad for me to say that, but I've just seen some really distressing things locally and in other countries. I've gone abroad on some mission trips and under the premises of faith-based work, and we were doing uterine prolapse surgeries in a certain community, and then I noticed that the women were leaving so quickly, and then they were going back to the fields to do all the work, and it was like the surgery never happened. I was like, why the hell would we do that? He said, oh, we can't deal with the cultural issues. I was like, holy cow, in fact, that's why we're here. So instead, we're doing surgeries that didn't need to happen. So I think we need to explore that and push a little bit more forcefully on what's happening under the guise of faith-based institutions. At the same time, there's some good work that's happening, so I think it's complicated, but they don't deserve a free pass. Nonprofit hospitals don't deserve a free pass. Faith-based institutions do not deserve a free pass.
One more.
I'll ask a question first. You mentioned the LWBs, the left without being seen. So in our emergency room, it can be common to be waiting for 18, sometimes 24 hours to be seen. And I think we do have a fair number of people that leave without, they might get the initial triage, but don't actually get the assessment that they need. So when you said that you have community health workers sort of track those people and follow them home, or what happens then? Do they bring them into care? What's the process there?
Yeah, I'm glad you asked me that because I need to unpack that more. So the left without being seen happens when a patient comes to the ER and he knows they're in a community like this, we have a lot of options. And you have patients there who are coming to the ER for non-emergent care. And that happens a lot. I'm sure it happens here. So what happens is that patient who's there for non-emergent care might not have access, so he's coming there, or she might not understand whether he's supposed to get the best care, or might be a frequent utilizer experiencing social issues. It's the commercial volume, those patients who say, wait a minute, I'm here to get care, and I have my young child witnessing things I don't want to see, or I'm not waiting an hour because there's people here who don't belong here. Those are the ones that are walking out. And I can guarantee if you study it here, it's a multiple seven-figure opportunity. So there's an obligation, I think, of connecting folks into hospitals in order to different care. Now the question you're asking is, what I did was I gave the community health workers iPads for those who had English as a second language and speak the language, or I gave them people who just didn't complete the application. So people come to the ER, start the application for insurance, Medicaid or others, don't complete that application, then we just write it off as a loss. What I did was say, no, track that patient. They got care. We can get paid retroactively for that. So that's the way the community health workers can work. And I think that Lisa Cooper's work can be leveraged to incite that. One of the greatest stories we had was a woman who was in Massachusetts, and she was known as a Medicaid lady in her community. They'd say, she would get you signed up for Medicaid. She can get you signed up for care. She became one of the greatest advocates for the organization. So I think it's an opportunity to transform and look from the outside in, as opposed to the inside out, what's in the community. Thanks for that. And thanks for your time.